And from the ultrasound to the gold standard of diagnostic.
Okay.
Dr. Grudeva, please.
Okay. Good morning, everyone. And first of all, thank you for the invitation. I'm glad to be here today. I'm a radiologist. And as we heard from the previous speaker, we have to go for the CT. So today I'm going to talk about CT assessment of intestinal ischemia. So intestinal ischemia was described long ago by Koukounis, a famous surgeon at that time, and he's pointed that this is a condition in which the diagnosis is impossible, the treatment is useless, and the prognosis almost hopeless. And unfortunately, something like 70 years later, pessimism is still shared by many, and it's stated that despite the advances in diagnosis and treatment, mortality still remains very high. And unfortunately, nowadays, numbers have not changed dramatically. And I think this explains the interest today to focus on exact and prompt diagnosis and aggressive treatment of this condition. We know from the definition that intestinal ischemia actually is a condition in which the intestinal blood flow is reduced to insufficient to maintain metabolic function. It comes from the Greek word, which means stopping of blood. But we know now that blood flow need not stop, but even when it's diminished significantly, it can lead to damage into the intestinal wall. And on top, it can have some additional reperfusion injury, which might even worsen the damage on the intestinal wall. So indeed, the mesenteric ischemia has very various phases because the symptoms will depend a lot on the extent of the disease, the severity, the location, the progression of the disease, the patency of the collateral vessels, and also the condition of the underlying vessels, meaning whether we do have or do not have atherosclerosis. And also, this is a clinical problem that is not very obvious, and very often patients do go different diagnostic tests prior to the diagnosis because the clinical presentation is not very specific. It was already stated that probably one of the most interesting things is that there is pain out of proportion to physical findings. Patient might experience nausea, vomiting together with the abdominal pain. Hematochezia might hint colonic ischemia. And also in the early phase, this can be accompanied with or without intestinal distension, while later on, as the disease progresses, we will have very gross intestinal distension, we will have lack of bowel movements, peristaltic, and very deteriorated status of the patient. So just a brief review of the anatomy that we all know, that the CMA is the major visceral vessel, and this is the most common place for occlusion, probably because of the high flow into the vessel and the acute angle of origin. And we know that this vessel is supplying from the duodenum to the proximal two-thirds of the transverse colon. Then we have also the inferior mesenteric artery that is supplying the distal part of the colon, distal to the splenic fissure. And what is also very important that we have collaterals in between these vessels, like the arch of Rioland, the marginal artery of Drummond. And this collateral will play a crucial role in cases of ischemia for the clinic of the patient and the presentation. And this is how this vessel, this anatomy look like on imaging. So you nicely see the 3D image where you can depict all the vessels. And just to remind you that we radiologists do not put our diagnosis on 3D reconstructions, rather than we prefer the raw data. So here on the left, you can see the coronal view, arterial phase, with the special, we call it maximum intensity projection reconstruction, and it's a reconstruction that is focused on depicting the vessels. So we know that mesenteric ischemia can be acute or chronic. We already have mentioned the types. We have occlusive type with occlusion either of arterial or venous vessel, and we have the non-occlusive type. Regarding the frequencies, the reported percentages differ, of course, among studies. There are not many data on it, but by far the most common one is, of course, the occlusive one. And what is interesting, that newer data suggests decrease in the number of embolic occlusions, and we suppose that this is because we better treat patients with atrial fibrillation or we prevent embolus more. On the other hand, I think there is slight increase in the non-occlusive mesenteric ischemia, and one of the explanations is that we have more patients critically sick being treated into intensive unit cares. So what are actually the CT appearance and what we see with imaging? Of course, the CT findings might be very variable, and they will depend on the location, on the severity of the disease. But I would say that rather we have two groups of features. First is the vessel features, and here we look for occlusion of arterial, venous vessels, of the stenosis, narrowing of the vessel walls. And in this case, the diagnosis is straightforward once we see these changes, or if we can depict them. So here on top you see an arterial phase, and you see the mesenteric artery nicely seen here an occluded segment in it, so the diagnosis is straightforward. And here on the lower image, it's a venous phase, so now we nicely see the portal vein, the splenic vein. However, in the superior mesenteric vein, there is a hypodense defect suggestive of venous thrombosis. Apart from that, we have changes into the bowel wall and mesentery. And there is a big spectrum of different changes that we might see, like thickened wall, distension of abdominal wall, and so on. And all this will depend on other features like having collaterals or not, superimposed inflammation, intramural hemorrhage. So, wall thickness. Normally, the bowel wall is up to 3 to 5 millimeters, but be aware that this will depend on the distension of the bowel. While in the bowel thickening, like this prominent thickening here, that's more than 1.5 centimeters, this is more prominent in venous thrombosis, while in arterial occlusion, the wall is typically thin. And however, this bowel wall thickening is not pathognomonic, so in differential diagnosis, we have here infectious and inflammatory disease. Attenuation changes. Generally, if we speak of ischemia, the affected segment is with low attenuation. As you see here, this segment of jejunal intestines that is with hypodense wall, non-enhancing, and that is due to ischemia and submucosal edema. On the contrary, sometimes we might even have high attenuation, and that will be in the case of intramural hematoma. And this we would better see on the non-contrast study. Bowel dilatation, that's quite an unusual finding, however not specific. We actually see more common bowel dilatation in mechanic obstruction of the intestines. In terms of ischemia, when we see a bowel dilatation, this is more pronounced in more advanced stages, so when we already have irreversible changes. And now you see here distended intestinal loops with air fluid levels suggestive of paretic ileus in this patient. Pneumatosis, or this was gas into the wall of the bowel. This is relatively specific, less common, hopefully because we see pneumatosis in the advanced stages, which already is indicative of irreversible changes. So how we see the pneumatosis, we have air within the wall, and how we differentiate it from air in the lumen. Generally, in pneumatosis, this air should be circumferential, and also it is not gravity dependent. We also might observe some non-specific findings like ascites, mesenteric stranding with this hazy appearance of the mesenteric fat, and so on. So just a few cases to illustrate. This is a 56-year-old female, a smoker with known previous atherosclerotic disease, and she presents with abdominal pain. So it's quite straightforward here from the sagittal view. You nicely see the aorta, we see the proximal part of the SMA, and here we have an occluded segment. And then if we see at the coronal view, the bowels and intestines, they look pretty well. There's no distended, not dramatic changes in them. Once again, the occluded segment. And this actually is a thrombosis of the SMA. And as was previously stated, very often this is acute on chronic, meaning that this is on pre-existing atherosclerosis. So it means that this patient might have history of coronary artery disease, of peripheral vascular disease, and they might have a history of postprandial pain that typically occurs something like half an hour after having a meal. Also, interestingly, these patients may tolerate major visceral artery obstruction due to the fact that this slowly growing atherosclerosis leads to development of important collaterals, and that's why we might not see infarcts or ischemia so prominent in their studies as in our patient here. The next case is a 55-year-old female, and she was with infectious endocarditis. She underwent surgery a few days ago, and now she presents with acute severe pain, with deteriorated state, and she's with suspicion of pancreatitis, and that's why she was sent to CT. And now, if we look here at these axials-wise, we see the pancreas looks pretty normal. There is not much changes. However, in this bowel, we see pneumatosis, and also we see the distended loops with air fluid level. The branches of the SMA are not very well seen, and we even have some air here within a vessel. And also a concomitant finding, we see that the right kidney is not perfused, and we have embolic occlusion also of the right renal artery. This also helps with the diagnosis, and it's arterial embolism, which is still by far the most frequent subtype of acute ischemia. We already know that the most common site of origin is, of course, the heart. But what is typical here is that usually the clinic is really dramatic because this is an acute onset and there is no collaterals obvious, unless there is, of course, prior atherosclerosis. Another case of a 77-year-old male patient with abdominal pain, lasting but aggravated. And now we see here on the non-contrast study that this intestinal loop is thickened like wall as compared to the surrounding, although again this is without prior distension. And then in the contrast study, we see this thickened wall, which is a little bit like a target appearance. If you see the mucosal layer is hyperdense, we have here the stranding, the fat stranding of the mesenterium. And if we look at the vessel, we nicely see the arterial vessels, the aorta, the celiac trunk, and the mesenteric artery in the arterial phase. But when we do the venous phase, now we can nicely depict the huge venous thrombosis in the mesenteric vein. And because this is the proximal, it's very easy and nice to see. It's much more difficult to see venous thrombosis if it's in the distal small branches, of course. And this is the case of the venous thrombosis. That's the less frequent one. And as we already know, it's accompanied by concomitant changes like hypercoagulation state, inflammation, or some other disease. Another case of a patient who is post-cardiopulmonary resuscitation. He was operated 2 weeks ago with aortic bypass surgery. And here is the CT 2 weeks after. We see the pneumatosis here in the ascending colon, which was a sign of irreversible changes. And then on the arterial phase, we do see the mesenteric artery, but if you look, it's a little bit narrowing distally, tapering, and we don't see nicely the branches. Same is here. We also see some underlying atherosclerosis in the proximal part. And even in the 3D, you see that the branches are quite less. So this is the non-occlusive mesenteric ischemia, which we know is associated with low cardiac output and diffuse mesenteric vasoconstriction. Another cause of mesenteric ischemia. So here is again one segment that is ischemic in the bowel, and in this case it was due to aortic dissection, and you see that the dissection also is involving the SMA. What about this case? It's a patient with intra-aortic balloon pump, and if you look closer, the balloon pump is positioned very low, so it's actually covering the ostium of the visceral vessels. And then if you look at the CMA distally, it's not well opacified and tiny. So in the end, I think that we are convinced that CT may be the new gold standard, as it can demonstrate the primary cause of ischemia by directly revealing the changes into the vessels, but also on top, it can give a lot of information of the coexisting findings, meaning the changes into the bowel wall and complication. And not surprisingly, it is included in the most recent guidelines with class 1 indication. So in conclusion, CT allows correct diagnosis and the extent of the disease, and it can be quite useful for appropriate treatment. And early diagnosis is really crucial, and it will decrease mortality. So be aware of this entity, send your patient to imaging, and we radiologists should pay attention and describe vessels in every patient with abdominal pain. And with that, I'd like to thank you for your attention.
Any questions from the audience? No? So the next presentation is by Dr. Alex.
Just one question. Sure. Because for the sake of treatment of the patient, other reperfusion in acute embolic cases or surgery, we have to know if this patient has bowel ischemia or bowel necrosis. Can you say it on the CT scan?
Exactly. I think that it's actually the main advantage of CT, and that's why still CT is the method that we use and not MRI. And because we are going to see all these changes in the bowel wall that I showed, of course, this is like a spectrum of findings, and it will depend in the time. But yes, we do have these things like the pneumatosis. Definitely, it means bowel necrosis. So these will be the findings that will suggest also the non-enhancing part of the bowel when there is pure ischemia and infarct. This is also suggestive that we have already quite irreversible and necrotic changes into the bowel. So this is the main advantage, I would say, for CT. And this is also very important how we perform the exam. And it is said that in some studies that, in fact, if there is clinical suspicion of the disease, then the diagnostic rates are higher. Because you know that with this imaging, we have different ways of tailoring our exams in order to see all these subtle changes. So in order to see these changes in the bowel, we need to have multiphasic exam to look really close, not only on the vessels, but also the bowel and so on.